Good afternoon. Welcome. I'm Janet Gatlin, and I'm with Rogers Behavioral Health. Thank you for joining us today. Joining me for this webinar are our presenters, Dr. Mitzi Kramer, our Medical Director of the Trauma Recovery, and Dr. Sonia Izmirian, the Clinical Supervisor of our Denver Clinic location, for today's webinar on sleep concerns. Shout out to our Sheboygan and Appleton clinics who are doing and they're hosting the in-person watch parties for today's webinar. So we're excited for those clinics. The webinar today is going to be scheduled for 90 minutes and you will receive CE credits. You must be logged into the webinar for the entire time. There's no need to check in. Your attendance is tracked via the Zoom login records. A PDF of today's PowerPoint slides and a list of the references will be available immediately after the program via email with a link to your personal dashboard on ce-go.com. In addition, a recording of the webinar will be published on the resource section of the website within a day or two of the rewatch. Our speakers will give a presentation today for 70 to 75 minutes. Following the presentation, I will host a Q&A session. You'll note that we have deactivated the chat feature for today as we found it to be distraction when the presenters are going through their presentation. I would ask that if you have a question, please use our Q&A button to send a message. This will be at the bottom of your screen. You can simply just click the Q&A button on the taskbar. I will review the questions that are submitted and the presenters will address the questions during the Q&A portion of the webinar, which will be the last portion of our talk today. Finally, we have enabled closed captioning for this program. At the bottom of your screen, there's a live transcription button. For that menu, you can click Show Subtitles to view any audio as text. If you'd like to disable the subtitles, please simply click Hide Subtitles from your live transcription menu. Now I'm going to go ahead and turn it over to our presenters. Thank you very much.
Hello, so I'm Dr. Izmirian. So I just wanted to start off with just kind of quickly going over disclosures. And so you all can read that we don't have any disclosures to declare. And then these are our learning objectives for this presentation. So you all can read that as well. And I think it was part of the information you all received when you signed up. And the big thing that we'll cover during today's webinar is really defining insomnia and nightmare disorder and reviewing some sleep hygiene strategies. And then we'll specifically go into strategies to address sleep issues. And then we'll also go over pharmacotherapy strategies for the treatment of insomnia. And then at the end, like Janet said, we'll have a moderated Q&A. So let's go ahead and get started. So first we'll define the insomnia and nightmare disorder and review some sleep hygiene strategies. So we'll start with insomnia disorder first. So this information was gathered from the DSM-5, and you can kind of reference that if you need more information. But what I put on the slides was really the main things that when it comes to insomnia disorder, the key thing is that a patient has to discuss having a dissatisfaction with their sleep quantity or quality as associated by either difficulty initiating sleep, maintaining sleep, or having a hard time with waking up early. So in children, it looks like these issues are typically presented when they have difficulty doing these things without a caregiver present. So the key thing when it comes to insomnia is that it's causing you clinically significant distress in social, occupational, educational, academic, behavioral, and other areas. And the key things are that it's happening at least 3 nights per week and for at least 3 months. This last point I think is actually really important as well, is these sleep difficulties are happening despite the opportunity to have sleep. So I think some things to kind of keep in mind for examples in this situation. There's some situations when you don't really have that opportunity to sleep. For example, if you're a parent with a newborn, you're not going to have that opportunity to sleep. So you will likely have some of those sleep issues. So I think that's a key thing to keep in mind when giving this diagnosis to someone. There are other information related to this diagnosis in the DSM that you might want to further reference. For example, like the specifiers and other information related to that. But I'll just reference the DSM for that, so you all can look at that later. So
Good afternoon, everyone. I'm Dr. Kramer. I'm going to be discussing nightmare disorder. I like this quote. It's from the 1980 novel, The Snow Queen. And I chose it because it pretty accurately reflects the dreamer's feelings of horror and helplessness that are prominent themes in nightmare disorder. So the DSM-5 criteria, you'll note that they use the terms extremely dysphoric and also well remembered when referring to the content of the dreams associated with nightmare disorder. Those dreams also revolve around frightening themes. So themes that you're being chased, that family members are in peril, threats to your survival or your physical integrity. As such, these can lead to avoidance of bed due to the fear of going to sleep and having a recurrence of these nightmares. So they can really affect sleep hygiene, and individuals with nightmare disorder struggle more with sleep latency. They also occur later in the sleep cycle, and clearly they're going to cause distress both upon awakening, but also the next day, because when you're recalling the nightmare, that's going to lead to significant impairment in functioning because you're recalling a distressing, unpleasant memory during the day. And nightmare disorder is going to fall under the category of parasomnias. Next slide. So nightmare disorder is a disorder unto itself. However, it's very commonly comorbid with other psychiatric disorders, the two most common being depression and anxiety. But you can see also schizophrenia, PTSD, borderline personality disorder. It's very commonly comorbid with borderline PD. Substance abuse, and then individuals who have suicidal thoughts or engage in self-harm urges also have higher prevalence of nightmare disorder. There's also a genetic component. So, for instance, it's common for individuals who have nightmare disorder to have a family member who also suffers from a parasomnia. So you may have nightmare disorder and a relative has, let's say, somnambulism, somniloquy, or even night terrors, for instance. Next slide. So the DSM-5 has two categories of specifiers. One is concerning the length of time of the disorder, and the second is about the severity of the symptoms. So acute, that's less than a month. Subacute is a month to less than 6 months. Anything greater than 6 months is considered to be persistent. There's also mild, moderate, and severe. And I can tell you that people who present to psychiatrists and therapists for treatment of nightmare disorder, they invariably have moderate, if not severe, symptoms. Next slide. So there are many differences between nightmare disorder, which is also called idiopathic nightmare disorder, and PTSD-induced nightmares. So idiopathic nightmares, they usually don't reflect a trauma theme or trauma events. They're more of those distressing themes, as I mentioned, loved ones in peril, fears for your physical integrity. As a statistic, 80% of individuals who have a PTSD diagnosis have nightmares. And so the nightmares, there are three clusters for PTSD, three symptom clusters. There's re-experiencing, there is avoidance and numbing, and then lastly, the hyperarousal. And the nightmares fall under the re-experiencing cluster. Also with PTSD-induced nightmares, there's more thrashing movements, there's more vocal utterances during the nightmares. And unlike nightmare disorder, it can occur during any time. So it can be upon falling asleep, it can be in the middle of the night. It doesn't have to be later in the sleep cycle. And then both nightmare disorder and idiopathic nightmares are differentiated from night terrors, in as much as night terrors, the individual wakes up confused, or they only partially awaken, and they're difficult to comfort after awakening. Next slide.
All right, so now that we've given those like overview of those two diagnoses, we're going to jump into sleep hygiene strategies. So the first one that I like to usually kind of go over is sticking to a schedule for when you wake up and when you go to sleep. And I think this is important to do for weekends and weekdays. I think the weekends are typically more of an issue when it comes to kids and children that we're, teens that we're working with, and also college students. So I think it's just something to kind of keep in mind. The second one is establishing a bedtime routine. So this is just kind of having like a pattern of things that you do right before bed that's pretty similar from day to day, because it kind of cues your body to go ahead and like remember like, oh, it's time to go to sleep. So let me go ahead and like get into that mentality. So some things can be like you turn off screens, change into your PJs, drink tea if that's what you like to do, turn down the lights, reduce the noise, read a book, brush your teeth, and then hop into bed. And you're like regularly doing that same thing in the same routine. So not eating or drinking too much right before bed. So the key thing here is when it comes to dinner, keeping it kind of like on the lighter side. If you're going to have a heavier dinner, you want it to be about 4 hours before you go to bed. But if it's a light dinner, 2 hours before bedtime is okay. But really limiting the liquids, spicy foods, things like that might like give you an upset stomach or indigestion. But I know sometimes, and I've experienced this too, sometimes you might go to bed and you're like, I'm actually really hungry. We don't want to go to bed hungry either, because that actually would keep you awake. So if you are hungry and when you're about to go to sleep, you might want to have like a light snack, like peanut butter, milk, cheese, something like that to kind of hold you over until morning. So the next one is avoiding or limiting caffeine, nicotine, alcohol, and cannabis. So the key things about like caffeine and nicotine, they both kind of act as this stimulant. For caffeine specifically, honestly, it depends on what you drink because they all have different levels of caffeine in it. But a general rule of thumb I tend to follow and recommend is no caffeine about 8 to 12 hours before you go to bed, or about like last one being right around lunchtime, noon. But again, highly dependent on the caffeine that you drink. Nicotine about 2 hours before bedtime, if you can. I know this is hard. This is dependent on the individual. The key thing here is if you wake up in the middle of the night, to not have like a cigarette or something that has caffeine in it, because that will actually stimulate you a little bit. So alcohol and cannabis both have the same effect of like, they'll help you fall asleep, but both of them actually impact your sleep while you're asleep. So I think alcohol usually makes it like restless sleep, and cannabis actually makes you wake up earlier than you would usually intend. So my general rule of thumb is to limit those to about 2 to 3 hours before bed as well. So regular exercise is typically helpful, trying to do it in the mornings or early afternoon. I think one thing is it kind of relaxes your body throughout the day, but I think the key thing about exercise is it actually increases your body temperature. And we'll talk a little bit more about this when we're talking about circadian rhythm, but your temperature is kind of increases in the beginning of the day and decreases as you're getting closer to sleep. So if you're doing exercise too close to bedtime, it increases your temperature right before bedtime, which makes it harder for you to fall asleep. Number 6, so keeping the room cool, comfortable, and safe. We don't want it cold. We kind of want it on the cool side, whatever. This is also individual specific as well, ranges from person to person. We also want it comfortable. So for this piece, kind of thinking about your mattress, your pillow, your comforter, how old are they? Do they need to be replaced? So every individual is a little bit different on that one. And then safe. So, this could depend on, do you feel safe in your home, whether it's the location or your partner? But also, if people have a history of, let's say, trauma and they haven't had trauma treatment yet, this might be a factor to kind of keep in mind as well. So, and then 7 being primarily sleep at night. So this one kind of falls into the nap category. So my general rule of thumb is I don't recommend napping for most adults and most children and teens. There are certain individuals that are an exception to this rule. So it's not a hard and fast rule. So if you are going to nap, the typical recommendation is for less than an hour and not after 3 p.m. So a couple more sleep hygiene strategies. So keeping it dark and quiet. So again, shades, turning the lights off, turning TV off. If you need a white noise machine, if you're kind of the person that doesn't like this complete quiet, I actually recommend getting an actual white noise machine or a fan. A lot of people tend to use TVs as their white noise machine. And actually TVs, our brains are programmed to pick up the cadence of people talking. So even if you have it at volume 2, our brain brain will still pick it up when there's like lulls in conversation. And when it goes from like the dramatic TV show to a commercial and it's all like loud and vibrant, our brains will pick that up and still like will actually stimulate you to stay awake. So, or have like less good quality sleep. So, so something to keep in mind there. No screens. I think most people at this point kind of understand that blue light piece of that'll keep you awake, but it's also just like, you know, when you're scrolling and you're seeing one thing and it's like popping up at you, that those things keep you awake at night. And so generally, like this one's a big one for teenagers as well, just kind of, and honestly for adults, but like no laptops, iPads, phones, TVs, video games, all of that. So number 10, using the bed only for sleep and intimate relationships. This one we'll talk a lot about actually in a few slides when we're jumping into the cognitive behavioral therapy for insomnia, but we want to be aware of what the bed is being associated with. We don't want to eat in bed because then you might get into bed and get hungry. You don't want to study in bed because you'll get into bed and be stressed. So we really want bed only to be for sleep and intimate relationships. So taking a shower or bath at night, one, it'll help you relax, but also again, mimicking the temperature of kind of going from a hot environment and stepping out of the shower to a cold environment signals to your body it's time to go to bed. Don't depend on sleeping pills or medication unless it's prescribed by your doctor. So I think this is a key piece there. And if it's something that you want to eventually get off of, this is something you can talk to your prescriber about and just determine, is it appropriate? Is it not? Do we want to titrate down? What do we want to do instead? So I think this just comes out as like a work collaboratively with your team. And then don't catastrophize. I think a lot of people have been in this situation where they're like, I'm not going to go to sleep. I'm going to be horrible tomorrow at work. I'm just like going to like mess up everything. And then, you know, I think the key thing there is a lot of the cognitive behavioral therapy work of, you know, it's okay, replacing that negative thought with a more neutral thought of, it's okay, I'll go to sleep eventually and I'll figure it out. I've done this before. So, and then finally, turning the clocks around. This one's an important one for whether you haven't fallen asleep or if you wake up in the middle of the night. Doesn't matter if it's 12, 1, 2, 3, 4. It's still not going to make you feel great regardless of when you woke up. So I think a key piece is to not look at the clock and stress yourself out more. So, and to apply it to the pediatric population, again, napping for babies and toddlers is a different story when we're talking about children and teens. So I think that's something to keep in mind. If you are working with a parent or personally a parent with a baby or a toddler, this book was recommended to me when I did my own sleep training. It's so really good about talking about how to get the parents and the kids to go to sleep really well. But generally babies like get sleep for babies, like the more they nap, they actually sleep better. So for children, every child's a little bit different. So there's not like a hard and fast rule on age for this one. So I think, you know, every parent knows their kids best, but a key thing when they're getting into older childhood and teenager is again, either no naps or really limit them to the rules we talked about before, so it doesn't impact them. Phone use, again, same thing for adults as for the kids. The only thing about kids is I would say, like, keep in mind if they take it to their room and they're like on their phone in the middle of the night, you might want to take their phone away if you're the parent or working with the team. And then just kind of looking at the research behind sleep with kids, a key thing I would say is that poor sleep is typically related and associated with emotion regulation issues in both teens and young adults and older adults. And it's also now more recent research is showing that it's related to a higher risk of suicidal ideation. So it's just something to kind of keep in mind as, you know, I think sleep is typically one of those back burner things when working with kids. And I think you just want to also address it too, so it doesn't impact these other areas. So now hopping into strategies to address sleep issues. So I'm going to start with, we're going to start with, you know, cognitive behavioral therapy for insomnia. So it's an evidence-based practice, and it's actually a fairly short one. It can be done in about 5 or 6 sessions typically. But again, every patient's a little bit different, sometimes more, sometimes less, depending on what's going on. And just kind of reviewing a lot of the research out there. There's a lot on here, but I'll just verbally review that CBTI, it improves sleep issues, but it also has the added effect of improving depression symptoms, sometimes anxiety for children, for adolescents and adults. And also in the older adult population, it's been shown to prevent depressive episodes from coming back. So, and they're also starting to do culturally tailored CBTI programs and seeing which ones are better for patients. And what this particular study, the third bullet point down, Zhu, if I'm saying that correctly, what they kind of showed is that, whether it was CBTI versus CBTI that was culturally tailored, both improved the sleep quality, but the culturally tailored version had more participants stay through the whole treatment program and less that fell through. So it's something to kind of keep in mind as you're working with culturally diverse individuals. And in terms of research for adolescents, it's growing. I think it just needs a lot more time to kind of get some more research support, but as it's kind of showing the same results, that it's improving sleep, anxiety, and depression symptoms as you're using CBTI. And then just to kind of jump in. So with CBTI, the first thing we really want to do is gather information to make a really good case conceptualization about what's going on. So usually there's an intake form. Everyone's a little bit different about what they want on their intake form, but the key things to kind of keep in mind are like, when did it start, their sleep issues? What meds are they on? What are their other mental health issues? What do they do when they wake up or they can't go to sleep? So a lot of gathering information generally. And the sleep diary is something that we usually kind of implement like pretty much day one when you're working with someone with and implementing CBTI. And the sleep diary, again, is like you're asking them like, when did they go to sleep? When did they get in bed? How many times did they wake up? For how long? When did they wake up? When did they get out of bed? And there's actually a really great app out there called CBTI Coach that has all of this. And I believe I had both Android and iPhone. I believe it's available for both. And if you don't like it, some people aren't app people, that's fine. We could do a paper chart version of it. But really, that's something that is implemented every day. And you review it at the beginning of every session. So some people like to implement measures as well. I think this depends on if you're a private practitioner, if you work in an agency. There's a lot of factors on this one as well. But the most common ones I was seeing both in the clinical and research realm were the Insomnia Severity Index and the Pittsburgh Sleep Quality Index. But honestly, there are a lot of different kinds of sleep measures out there, depending on what specifically in the sleep realm you want to target. They are, honestly, you can Google them and see the questions, but to be able to access them, both of them have different websites to link to, and just see if, like, for your purposes, whether it's research or clinical, you can access it for free or if you have to pay a fee. So to jump into the basic strategy or principles of CBTI, there's really three components to get the formula for good sleep: low arousal, a correct circadian placement, and strong sleep drive. So I'll go through each of these in the next slides. So for low arousal, the key thing, at least the term that it's used in the CBTI world, is stimulus control. So the reason is because insomnia is considered a disorder of conditioned arousal. So this goes back to one of the sleep hygiene strategies where sleep is only supposed to be used for, or bed is only supposed to be used for sleep or intimate relationships. What's ended up happening for a lot of people with insomnia is you'll talk to them, feel like, I'm so exhausted, and then I hit the bed and I'm wide awake. So, and what happened was their bed got associated with high arousal in some way. So again, every person's a little bit different. So it's similar to kind of like Pavlov's dogs, where the bell gets associated with drooling. We have to unlearn this association between the bed and high arousal. So to do that, for a lot of people, we do these strategies below. So we only want to be in bed when you're sleepy and not tired. So this is the difference too. I think it's hard to kind of describe this one too. With, like, tired, you can be tired after doing a really excessive, like, intense workout, and you can still be tired, but you're awake. But sleepy, I usually kind of think about it as like you're at the point where your head's nodding off, like that's sleepy, and that's when you should get into bed. So and then the key thing, and I think this is honestly the hardest part, is if you have not fallen asleep in 15 to 20 minutes, you get up and go do something. And it's not that you're looking at your clock like, oh, it's been 5, oh, it's been 10, oh, it's been 15. Because remember, one of the sleep hygiene strategies, we don't want to be looking at that clock. You take a guess. It's like, honestly, we would kind of just use a mentality of, has it been like, when you're not going to go to bed. If you know you're not going to fall asleep right now, just go do something. The key thing for what they're going to do when they wake up in the middle of the night and get out of bed is no electronics. So no TV, no phone. Those are the typical go-tos, but it could be gaming, it could be iPad, it could be anything. And you really want to find an activity that's actually going to tire you out a little bit. So puzzles, Sudoku, read a boring book, not like a mystery novel that's going to hook you in. So knitting, sewing, that kind of stuff, if that's what you like to do, but something that's going to tire your eyes out. And then when you're at that point where, again, you're sleepy, get back into bed. So circadian rhythm, I will say is actually, there's like a whole lot of research on circadian rhythm. So I'm just going to touch on it here. But when it comes to circadian rhythm, this is, and I'll have an image for the next slide, but this is really how much your body is telling you that you should be alert throughout the day. Some people are morning people, some people are night people, and some people are right in the middle. And so the key to strengthening it is actually kind of waking up the same time every single day. Actually having some sunlight throughout your day can help with that circadian rhythm piece, and just having regular activities. For this slide, so you'll see kind of the way circadian rhythm goes and the way sleep drive goes. And we'll talk about sleep drive in the next piece, because that's that third part of that formula to get good sleep. But circadian rhythm, gradually throughout the day, you're going to get, you're going to start off with low alertness rhythm, like alertness level, and gradually get more. And then when it's time to go to sleep, your alertness level should go down. And what's happening with insomnia is that the sleep drive and circadian rhythm are not lining up. And so what we want to do is to strengthen the lineup of the two. And we'll talk about sleep drive too. Sleep drive is that third piece. We want you to want sleep. We want you to need sleep. But if you're like napping throughout the day, it's as if like if you're hungry and you take a snack, you're not going to be as hungry when it comes to dinner time if you're just snacking throughout the day. So what we want you to do is to not snack throughout the day, not nap throughout the day, and be really, really tired so that your sleep drive, your sleep hunger at the end of the day is really high. So that's part of that formula to try to increase that good quality of sleep. So that sleep drive now goes into this third part, or this, like I really think about it as the second part of CBTI training, which is sleep restriction therapy. So I know when I'm talking to patients about it, that is a scary term. You're going to restrict my sleep? What are you doing? I'm already tired. I'm already sleepy. Why would you restrict my sleep? So if that term might scare some of your patients, I would say actually use some other words like sleep efficiency training, sleep quality training, because that's really what we're trying to do with sleep restriction therapy is we're trying to narrow the amount of time that they're in bed until the quality of their sleep gets better, and then gradually increase it. So if you look at this image, the first line is what we typically see as somebody, what a typical person with insomnia might experience in bed. They're awake, they're asleep. They're awake, they're asleep. They're awake, they're asleep. They're awake, they're asleep. So the time that they're in bed, that's the TIB, is long, but the amount that they're actually sleeping is not a high percentage of that time in bed. So what we typically do is we actually calculate, like add up the time that they're sleeping. And let's say that's about 5 of that 8 hours. And that's what we're going to start off as. We're going to limit the time in bed to be the typical average time that they actually sleep in bed, not that they're actually in bed. So, and then as that quality, as the quality of the sleep increases, then we gradually increase the time in bed. We don't want to do it too fast, because if we do it too fast, they might just hop back in to the first line. We want to do it gradual so that their sleep stays a higher majority of the time that they're in bed. So, so the way that we do that is by creating this sleep efficiency number. So that's why we like to call it sleep efficiency training instead of sleep restriction therapy, if we want to make it less scary for the patients when they hear that. So with sleep efficiency, you are getting the total sleep time. And again, this is all based on that sleep diary that they're doing. So if we don't have that sleep diary information, really it's hard to do the sleep restriction therapy. So you're getting that total sleep time and you're dividing it by the time that they're in bed. The goal is 85%, because even the best sleeper out there is not sleeping 100% of the time that they're in bed. So 85% is about the average. So when we're first figuring it out, if their efficiency is not great, we can either keep it at the same time in bed, or we gradually decrease it if we need to. The key piece here for step 1 is we don't want to go below 5 hours. So even if they're reporting that they're like actually sleeping only maybe 3 out of the 6 hours that they're in bed, we still want to keep it 5. We don't want to go too little that we're impacting their like ability to function throughout the day. So minimum amount of time that they're going to be in bed to start off with, it will be 5. So, and then again, we calculate that number across the average for the week between the sessions that you meet with them. And if that number is 85% or more, then we can up the time in bed by 15 minutes or 30 minutes if they're really, really sleepy. So just to give you an example, if their sleep efficiency is 85 and we started off at 5 hours and 30 minutes, so that they're in bed, we would actually just up it to 5 hours and 45 minutes. So, and you can work with the patient on when you want that to start and when you want that to end. But if they're at the point though that they're like, I'm like can't function, I'm really like sleepy throughout the day, you can go from 5:30 to 6 hours in bed. So when it comes to guiding your sessions, my typical thing is across the first few sessions, these are the 7 strategies that I typically review. I kind of, in my mind, this is the way I conceptualize it, I put the stimulus control and sleep restriction therapy, those are the really 2 main components of CBTI, as like what I think is kind of happening in each of those. So my general go-to is usually by session 1, like after the intake session, the first like therapeutic session, I'm going 1 through 5. So you're waking up at X every single day. This will depend on school, work, what their expectation is, like 7 a.m., 8 a.m., whatever it might be. That's actually working with the circadian rhythm as well, but it's also stimulus control. We want them to get out of bed if they're not asleep. And it's also sleep restriction therapy. That's part of like when we want them out of the bed, if it's within the whatever hours that we want them to be in bed for. Point number 2, go to bed when you're sleepy. So stimulus control, but not before X. This is when you're going to implement sleep restriction therapy if you're at that point to implement it. So again, if somebody has to wake up at 7 a.m. and the goal is for them to only be in bed for 6 hours, they have to go to bed at 1. so like that's hard for a lot of people to do, right? So we're going to have to talk about that, and we'll talk about it in a couple slides below, but the goal is you got to find something for them to do until 1 a.m. and then they can go to sleep from 1 to 6. So the third one, get up when you can't go to bed. So again, stimulus control, not wanting to associate bed with something stimulating. Use the bed only for sleeping, stimulus control, and avoid daytime napping. Again, that's stimulus control. And it's actually in my head, probably more sleep restriction therapy too. So of like trying to increase that sleep drive throughout the day. So then eventually session 2 or 3, I usually will cover the create a buffer zone, which is just basically like an hour or so before bed. Again, going back into create a routine, dim the lights, stop electronics, drink your tea, read a book, and then don't worry, plan, or et cetera in bed. And this is where you can actually include a lot of other strategies that are outside of CBTI. So if they are a worrier, you might be able to include cognitive behavior therapy, ACT, acceptance and commitment therapy, maybe some DBT skills, dialectical and behavior therapy. Depending on the individual, whatever they're doing, you can actually include other aspects of different therapies in the therapy to figure out what's working. So, and just for a lot of my patients, I will usually do 1 through 5 for like the first initial session, but I won't do the second half of number 2, sleep restriction therapy. That's a key component of sleep restriction therapy until usually session 2 or 3, just to get some more data from their sleep diary and just to help them feel ready to do sleep restriction therapy. But again, some people are like gung-ho ready to do it. And if they are, then you can do sleep restriction and stimulus control all in the beginning. So this is the nice thing about CBTI. It's flexible, and it all depends on what are the main components that are impairing the person's sleep. So, and then my last slide when it comes to CBTI before I hand it back off to Dr. Kramer is how to guide your sessions. So really at the beginning of each section, again, you're getting that sleep diary data every single week, and then you're calculating that sleep efficiency score. And I'll be honest, the first time I did it, it took me a while. It took maybe like 20 or 30 minutes of that session where I'm just like, what was day 1? Cool. And you're just typing it in like line by line, and you're calculating in the Excel form. But really, after you get the hang of it, it gets faster and faster. And then what you're doing for the second half of every session is you're determining all right, what's their sleep efficiency? Is it at 85 or lower? Do I need to increase or decrease the time in bed by 15 minutes? So then you're doing other strategies. You're like, do we need to work on cognitive restructuring because they're having anxious thoughts? Then we'll go over that strategy. Do we need to figure out how they can decrease their arousal because they're just so amped up? All right, we might do some relaxation strategies, progressive muscle relaxation, breathing, or we might have to review some sleep hygiene strategies that maybe you've reviewed already with them or not. They just might need a refresher and to kind of focus in on what they need to do. So that's a general guide of CBT for insomnia. And I will say this is a very big overview, and there's a lot of nuances when it comes to various diagnoses. And so we'll talk about resources at the end about if you want to pursue this and get more training. So.
All right, so I'm going to talk about imagery rehearsal therapy, which is a treatment for both nightmare disorder and also PTSD-induced nightmares. It is a CBT, evidence-based approach, and it focuses on altering nightmares and gaining control over distressing images at night. What essentially occurs is the patients modify their nightmare narrative via repeated exposure to a new narrative. So it's about re-scripting. And the goal is to change the nightmare script while awake so that it's no longer threatening. And then you repeatedly rehearse the new narrative in which the patient is in control. So several randomized controlled trials have been conducted on this type of therapy. Nearly all of them showed vast improvements in nightmares, improvements in sleep quality, and a decrease in overall psychiatric distress. In addition, a robust, clinically significant reduction in nightmare anxiety. So anxiety about going to bed because you're fearful you're going to have a nightmare. That was most noticeable in individuals with idiopathic nightmare disorder. However, there was still a moderate reduction in those also who had PTSD. IRT also decreased PTSD symptom severity across all three clusters, which we did not expect. And that's based on the CAPS, the clinician administered PTSD scale. Next slide. So this diagram is a bit busy, but I wanted you to conceptualize how IRT is based on an integrative model of etiology of nightmares. And that's going to include both impaired fear extinction as well as hyperarousal. And we will discuss all of that in our next slide. Next slide, please. So nightmare etiology. After Sigmund Freud's death, there was a stronger emphasis now on the study of dreams from the perspective of neuroscience. And Dr. Mark Sohm, he's a psychoanalyst. He's written extensively on the neurocognitive theory of how dreams are generated. He also observed that dreams can be independent of REM state. So though most dreams do occur during REM sleep, not all occur in conjunction with REM sleep. The theory for dreams is that the cerebral cortex, which synthesizes information during the day, it's activated during sleep, and then dreams are the brain's attempt to try to make sense of all of that information. What happens during nightmares, however, is you're hyper-aroused during the day, and that's caused by either stress, emotional dysregulation, heightened threat perception, and that makes certain areas of your brain hyperactive during sleep. And so the amygdala, that's associated with emotional processing. So fear, anger, anxiety, also pleasure. A hyperactive amygdala, what it does is it leads to impaired fear extinction. So individuals with nightmare disorder, they continue to activate fear memories in their sleep. So there's a correlation here in as much as individuals who have difficulty regulating their emotions during the day are more prone to nightmares. Next slide. So other takeaway points for nightmare etiology: traumatic experiences during adulthood and also severe childhood adversity. That's going to lead to a heightened threat perception. And then there's this concept of trait susceptibility. Nightmare sufferers are usually really good candidates for therapy, and here's why. They exhibit increased depth of processing for negative, but also for positive stimuli, and that includes implementing mindfulness techniques. So also, if during the day you're suppressing negative intrusive thoughts, it's going to increase the probability that those unwanted thoughts are going to recur in dreams. And then lastly, there are several studies that show a correlation between disordered sleep breathing associated with obstructive sleep apnea and nightmares. And so there's a significant improvement in nightmares when OSA is effectively treated with CPAP. Next slide. So IRT is the best researched and the most widely used protocol for employing imagery techniques in treating nightmares. We use it all the time here in my trauma recovery residential program. In fact, I'd say at any given point, in addition to doing prolonged exposure and schema work, about a third of my patients are doing imagery rehearsal therapy. And it's recommended level A by both the Oxford Center for Evidence-Based Medicine and also the American Academy of Sleep Medicine guidelines. And so how this works in a nutshell is you have the client write out a narrative which has central elements of the nightmare as close to the event as possible. So this is best done by keeping pen and paper at bedside. Sometimes they have a recorder by their bedside and they wake up and they record the nightmare. And so later you turn those notes or that recording into a detailed narrative, and that's going to describe the events. And it's really essential to capture the most frightening elements on paper. So actual injury or death, horrific images, sights, sounds that they can recall. Then you rewrite that story so that it has either a neutral or a positive content. And it's one in which the patient is empowered and they are in control. And then you rehearse. So after you've rewritten the script, you want to rehearse that rewritten script 20 minutes a day. And we usually do it 3 or 4 times a day. And that displaces the unwanted content when the dream does occur. And it empowers the patient to implement the new script. And so you repeat this procedure. You want to experiment with rewrites if you don't have success on the first attempts. Next slide. So the take-home message is this: IRT provides a cognitive shift that refutes the original frightening premise and the content of the nightmare. And so if you look at randomized controlled trials, this treatment demonstrated statistically significant improvements, both in idiopathic nightmare disorder and PTSD-induced nightmares. It's very effective, and it's also extremely well tolerated. Next slide. So there really is no FDA-approved pharmacotherapy for treating nightmares. So everything we do here is off-label. So the cardiovascular system, it has alpha and beta blockers. We use the alpha blockers, that's prazosin, doxazosin, clonidine. Again, it's off-label. And what it does is it targets that autonomic arousal, that fight or flight. So they can be used to treat hypervigilance during the day, nightmares at night. It's an adjunct therapy according to the American Academy of Sleep Medicine. Again, the reason that it's adjunctive is this conflicting data. So in 2018, there was a very large scale multi-center trial that came out that said that there's no benefit whatsoever to these alpha blockers. And then the next year, another very large trial came out that said, you know what, these are actually more effective than we once thought in reducing nightmares and improving sleep quality. So due to this conflicting data, it's not level A like IRT is. There are other off-label options. There's topiramate that works on glutamate, gabapentin, cyproheptadine, the tricyclic antidepressants. But again, none of these have an FDA indication, nor are they considered level A treatment. When someone is on alpha blockers, I always advise caution with positional changes because these meds are essentially antihypertensives. They're not first, second, or even third line for treating hypertension, but they can lead to something called orthostatic hypotension, which is upon positional changes, your blood pressure drops too low or your heart rate goes up too fast, and you get spinny and pre-syncopal. Next slide. So if you're looking at considerations, oh, I'm sorry, this is you.
Yeah, sorry. So we're going to do considerations for implementation for both CBTI and IRT. So for CBTI, I think the key question and barrier that typically comes up when working with patients is, what do they do when they're awake? So, because there are some people, especially when you're doing sleep restriction therapy, they're typically go to bed at 9 p.m. and, and we're telling them to go to bed at 1 a.m. And, what are they going to do? So we have to find activities for them to keep themselves awake. Again, we don't necessarily always want to rely on TV sometimes, or like electronics of other kinds. That might be the last resort sometimes, but really it's about like, do they need to stand up and go for a walk, even if it is at, in the midnight or something like that, no extreme exercises, but is it like, do they need to do an activity, like read that horror novel that's going to keep you awake for a little bit? And then, activities that people might need to find to help, to help them fall back to sleep when they wake up in the middle of the night. We might have to help them find something that's a little bit boring, tiring, something that might they might have not have tried before, or they might have tried, but we might have to have them try again. So, and then one thing that sometimes happens for patients with anxiety is that they have that anxiety that impairs them from either going to sleep or going back to sleep. We might have to help set up a time. So like even before their 1 hour buffer zone right before bed, you might actually just have them write down all of their anxieties and worries on a sheet of paper at let's say 5 p.m. at night, and just get it all out. And if they can problem solve even one of them, it actually might just make them feel better. The goal is not to necessarily problem solve all of the worries that they have, because that probably isn't possible, and not all of their worries are solvable. So I think just sometimes just getting it out of their head is a little bit better to help them fall asleep. One really big thing to think about when it comes to shift workers who might have insomnia. So shift workers are an interesting case. I mean, ideal world, we wouldn't want them on shift, like shift working, if they're having sleep issues. But some people can work on shifts and they don't have any issues with sleeping. So, these are really for those individuals who are working shift work and having insomnia. So one thing is, preferably if you are gonna have to work shift work, you stick to the same shift. So if you're gonna do day shift, you're always doing day shift. If you're doing night, you're always doing night. If you're doing mid, you're always doing mid, because then you're doing the same CBTI work but just shifted. So instead of going to bed from, let's say, 12 to 7 a.m., then you might just be shifting it to potentially even 12 p.m. to 7 p.m. So you're just going to be shifting it. The only issue that's going to get in the way with shift workers is circadian rhythm. Our bodies are intended to sleep at night, and, we get sunlight that helps us wake up. But if we're shifting it, that's going to impact it. So CBTI just might not be as effective for shift workers. And then for, let's say, truck drivers or people who drive long distances as part of their work, or just generally speaking, it's going to be hard for them to do that first couple weeks of sleep restriction, because they're going to be really, really tired and really, really sleepy, which is great for sleep drive, but not great for safety when you're driving long distances. So these are one of the exceptions that I make for the napping rule, are truck drivers that are doing long distances. You might let these individuals take a nap, because we do not want them behind the wheel if they are at the point where they're falling asleep. So the other alternative for people who drive long distances is, if they have the PTO saved up, to take 2 or 3 weeks off, again, ideal world, just to do those first couple tough weeks of sleep restriction therapy. And then once they get their sleep quality back, we can get them back to work and continue the CBTI work.
Okay, now we'll talk about considerations for implementing imagery rehearsal therapy. The impact of nightmares on sleep needs to be recognized and conceptualized as a learned behavior. And so there are 4 sessions total. The first 2 sessions, you're going to focus on the concept of learned insomnia. And then the next 2 sessions, you're going to do the imagery therapy. So nightmares can be treated effectively with this approach without delving into prolonged exposure or focusing on past traumatic events. So this type of treatment, essentially, it's going to minimize exposure therapy. That being said, keep in mind that a patient with PTSD may need to discontinue IRT therapy if it leads to triggers that are so significant that it causes a marked uptick in trauma response. So know your patient's limits. Next slide. So both of these studies I found fascinating. This is about prevalence rates of sleep disorders among the LGBTQ population. So the research was a longitudinal study. It examined sleep problems among sexual minorities. A statistic that doesn't have to do with sleep, but I think is really impactful nonetheless, is that more than half of transgender patients have at least one DSM-5 diagnosis. And that's compared with 13.5% of cisgender patients. So that's more than 4 times the prevalence rate. Depression and anxiety are the most common. And then the disparities with sleep disorders are also pretty remarkable. So the LGBTQ population, they experience less overall sleep hours. They struggle to fall asleep. When they do fall asleep, it's a poor sleep quality. And then when they wake up, they feel unrested and they feel fatigued. Next slide. So the possible determinants here, one is there's a higher rate of discrimination against this population, and also higher rates of violence. And then this can lead to higher prevalence of PTSD. And in turn, that can lead to PTSD-associated nightmares. So focusing on the social support networks beginning in childhood among transgendered persons could be a critical intervention that could help reduce the development of mental illness and sleep disorders in adulthood. Next slide. All right, we're going to go over some pharmacotherapy strategies for treating insomnia. Next slide. So there's a difference between what the FDA recommends and approves and between the American Academy of Sleep Medicine guidelines, which is the gold standard for clinical practice guidelines. So a strong recommendation from ASAM is one that clinicians should follow. A weak recommendation reflects a lower degree of certainty, and there are no pharmacotherapy agents in our arsenal that have a strong recommendation from the Society of Sleep Medicine. So the Z drugs, so Zaloplan, Zolpidem, so that's Lunesta Sonata, and those medications, they have a very weak indication for sleep onset and sleep maintenance. So falling asleep, staying asleep, as does temazepam, which is a benzodiazepine. Doxepin, which has an FDA indication for insomnia, depression, and anxiety. It only has a weak indication for sleep maintenance only, according to the American Academy of Sleep Medicine. And then triazolam and Ramiltian. Triazolam is a benzodiazepine. Ramiltian is a melatonin receptor agonist. They both have weak indications, and it's for sleep onset only. And so really the interesting thing about this is the medication that we use almost universally is trazodone. So it's a very popular medication. It's the PRN on a lot of inpatient units because it's well tolerated. Not a lot of drug-drug interactions, but the American Academy of Sleep Medicine suggests that clinicians don't use trazodone, Benadryl, melatonin, or valerian due to lack of evidence for efficacy. Now, to kind of explain this a bit further, a recommendation against these pharmacotherapy approaches is not equivalent to ineffectiveness, but rather what they're saying is that an indication that data lacks sufficient evidence to provide convincing support for their use. So because of the lack of data, they're not, the ASAM is not convinced that they should be used. And again, that's different from FDA approval. Next slide. So this is what I said. It's in a chart form. It lists out the medications, whether they have a weak or no indication for treatment for insomnia. And we can go to the next slide. Now, these agents are fascinating. These are newer. These are the newer pharmacotherapy agents. They're approved by the FDA for treating insomnia, both sleep maintenance and sleep onset. And they're called the orexin receptor antagonist, suvorexant, limborexant, and then the one that came out very recently is daridorexant. And so what they do is they work on the sleep-wake cycle, and they suppress wakefulness. So they're kind of the opposite of the meds that we use for narcolepsy and idiopathic hypersomnia. So those meds promote wakefulness, and those are orexin receptor agonist. These are antagonists. So, you know, what they're doing is they're suppressing that sleep-wake cycle. And so a study came out, it was actually 2 weeks ago, in the Journal of Clinical Sleep Medicine. And it indicated that among these three, limborexant in particular, showed both subjective and objective benefits in treating chronic insomnia. So keep in mind, there's this discrepancy that I mentioned between the FDA approval, which indicates statistically significant benefits when compared with placebo, and between the American Academy of Sleep Medicine guidelines. So the sleep medicine guidelines employ different criteria with different clinically statistical thresholds and standards than does the FDA. So medication can have an FDA indication and an approval for treating insomnia, but the American Academy of Sleep Medicine may not feel that it's an appropriate med due to their threshold and their standards being different. Next slide.
All right, so I'm going to actually go over a case example of an individual that I completed a CBTI with. So I'm using the addressing framework to kind of go over their background information, but I added an O for occupation just to give you some background about this individual. So this individual is a female, is identified as a female, cisgender, and they were in their mid-30s. Their diagnosis was post-traumatic stress disorder and insomnia disorder. So disability and health status information, they were able-bodied, overall good physical health. Religion and spirituality, I know we asked this question, but I'll be honest, I don't have access to this person's case files because it was from a previous employment. So I just don't know it off the top of my head. Ethnicity and race was white, and their sexual orientation was bisexual. Their socioeconomic status was middle class. They were, their occupation was a nurse, and I'll kind of go into why that kind of plays a key role when it comes to the trauma piece. They didn't have any indigenous heritage that they were aware of, and their national origin was US citizen. So, and the nurse piece is because they actually had multiple traumas, some related to their childhood, but also they just experienced a lot of trauma in their nurse day-to-day job. And you just kind of like just a lot of helping individuals. So I think they just had chronic trauma. So other factors for this particular case example that I think are important for what we're going to talk about today is they had 2 children that they lived with about 50% of the time. They had shared custody with their partner, and they had ill parents that they were taking care of. So these are factors to kind of consider when you're just like the day-to-day life things that can get in the way whether we're talking about treating the trauma or treating their insomnia. So, and with this particular individual, what we did first was we focused on the trauma. So when I went through my own CBTI training, you know, the question often comes up, which one do we cover first, trauma or insomnia? And honestly, it highly depends on the individual. And I would say this is generally true for most other comorbid issues when it comes to insomnia. Which one are they willing to start doing? Like work with, like if they're, and which one is causing the most impairment. For this individual, the trauma was causing the most impairment and they were ready to do prolonged exposure. So I'm like, if somebody's ready to do trauma work, let's do it. Like we don't want to hold that off because trauma impacts so many aspects of their life. But we, as I think a lot of clinicians and providers know, some people are just hesitant to jump in and talk about their trauma. And so we have to consider, like, can we go ahead and do the sleep work first and then address the trauma afterwards? And you can. So in at least in the CBTI world, like if they're willing to do the sleep work and then address the trauma, let's do it. Like we can go in different orders. So for this individual, we did do prolonged exposure to address their trauma, and their most important trauma was actually related to helping an individual, like a stranger on the street, that ended up passing away after a car accident. So I think their occupation as a nurse played a key part in just the day-to-day interactions with strangers, patients, and honestly their partner too, because they just tend to be a helpful individual, but their helpfulness put them into a lot of situations where there was a lot of trauma involved. So I think when it comes to both their trauma and their sleep, it was negatively impacting their life in a lot of ways. It was impacting their ability to function and stay awake at work. It was impacting their interactions at home, their ability to take care of their ill parents, their children. And so once we did prolonged exposure and addressed the trauma, then we were ready to jump into the sleep, and we did CBTI. Fortunately for me, she did an amazing job tracking her sleep. I think, again, no one's perfect, but she did a really good job of tracking the sleep diary from day to day. And just some things to kind of consider. These were some treatment interfering factors kind of we addressed throughout our work together. So sometimes when partners come over, especially if they don't live together, sleep schedules get skewed for whatever reason. You might be staying up late to watch a movie, intimate relationships. So like every so often I'll just see like, oh, she went to bed at 3, like what happened? And so, and I think this is actually the great part about reviewing the sleep diary at the beginning of sessions. It gives you a lot of information about what's going on. So without reviewing the sleep diary, you don't actually know the day-to-day issues that are impairing their sleep. So other things that we kind of noticed with her was, actually with the partner, before I go to the next point, when it came to the partner, I think just generally when partners are involved, whether they live in the home or not, getting them involved and keeping them aware of what we're doing with CBTI is really important. So for this individual, we were just like, hey, you might want to like talk to your partner and just like tell them to let's keep the like 3 a.m.s to a minimum, at least until we figure out the CBTI piece. And then you can potentially have some variability in your sleep. But generally partners, I think we want them as a support individual. So if someone's having a hard time staying up until 1 a.m. when they're doing sleep restriction therapy, your partner can be a support, and like they can stay up with you if they can, or like at least try to figure out like different ways to set up the sleep situation so that they're not getting in the way. So if let's say you have a partner who snores, that makes it hard for you to sleep. That's a factor we need to keep in mind. Going back to this case example, this individual, their 2 children regularly just kind of came in bed, whether it was for snuggles or sleep and things like that. So we did have to have a conversation about like having their children stay in their own bed because that was interfering their sleep. If you're a family that co-sleeps and it doesn't bother your sleep, then it's not a factor we have to address. So again, I think it's really patient specific. This individual had a lot of noise outside by their window in the apartment that they lived in. So it was something that we had to kind of address with white noise machines, fans, keeping their window closed instead of open, even though it was hot. And so because of that, we needed the fan to cool her off, going back to the sleep hygiene strategies of keeping the room cool. So, and then this individual also had migraines. And for them, sometimes it's really hard to get out of bed when you have a migraine and you just want to sleep and lay down. So the key thing here goes back into stimulus control. Again, we want, because migraines, you're not necessarily sleeping. I mean, sometimes you are, but sometimes you're not. You're just like, it's a lot of pain. We actually want them to get off of the bed and go to the couch if at all possible, if they're able to do that. I think that one took probably the most convincing for this individual. I was like, you can get out of bed, you can do it, just go to the couch at least, even if you are laying down, to address the migraine. But I think a lot of this, like if they can't actually physically get out of the bed fully, then some things we might want to think about is like just modifying it a little bit, maybe sit up in bed, maybe try to like shift things around in their room. So I think this is a lot of things to kind of keep in mind. And with this particular individual, they had a lot of people actually living in a very small amount of space. And that actually happens a lot with the people that we're treating. So if you think about a college student who might be living in the dorms, who might be living, or an individual living in a 1-bedroom studio, the bed might be the only place to sit. And so we might have to potentially be like, cool, you can only sit at the foot of the bed, or you're going to get chairs and bean bags back in the day, and like sit on those instead of your bed, a nice little carpet on the floor. So I think kind of thinking about, we still want to keep the bed as only a place to sleep and for that particular individual and not other individuals who might be interfering. So, and for her, it was the migraines and the couch situation. And she had lots of individuals in her home. I think her ill parents were actually sleeping in her living room. And so it was just like, okay, where can we find a place for you that feels comfortable, that you can go to, that's not your bed, but that you can like have the migraines in that particular location. So I think this is just kind of an example of one way of doing cognitive behavior therapy for insomnia. And every patient is different. You're going to have different interfering behaviors depending on the person that walks in. And I think you just got to work with the individual about what's going on. So. And I think we're ready for, some Q&A.
That sounds great. Thank you. Well, thank you. Now it's time for some Q&A. If you have a question, please go ahead and use the Q&A button, not the chat feature, and that will be located on your Zoom taskbar. We'll try to get to as many questions as we can. And it looks like we do have quite a few great questions to be able to answer today. So thank you for those of you who already have typed some questions in. I will be combining some of the similar questions that have already been listed. And if we do not get to your question, please feel free to send an email message afterwards to webinars@rbh.org, and we'll follow up with you. All right, so let's go ahead and get to some of those questions that have been typed in on the Q&A portion. Let's see here. If someone does not have a stable sleep schedule or routine and good sleep hygiene, do they qualify for an insomnia diagnosis?
If they don't have a stable sleep schedule, and what was the second part of it?
Sure. Do they qualify for an insomnia diagnosis?
If they have ample opportunity to sleep. So even if somebody has like shift schedules that like move around, if they have time to sleep between those two, like between the shifts, then I believe they should still be able to qualify for that diagnosis.
Great. A next question here. How many hours before going to sleep should clients avoid exercise?
I think my general rule of thumb is about 4 hours. That's kind of what I have in my like notes from my experience in the training, but generally 4, it gives them enough time to like let their body cool down and relax, as opposed to being amped up, both temperature wise, but also like adrenaline wise.
Okay, great. There's several questions here about melatonin. Is melatonin included in the medication and pills category in the not to use for sleep hygiene? And I know you did address melatonin in some capacity.
Yeah, and so again, there really is a difference between what the FDA approves and what the American Academy of Sleep Medicine approves. The American Academy of Sleep Medicine has really no strong indications for any medications, including the ones that have an FDA approval. Melatonin, of course, is over the counter. Rimiltian, which is Rosarum, works on both melatonin 1 and melatonin 2. So that's actually by prescription. That has that weak indication by the American Academy of Sleep Medicine. It is more effective than over-the-counter melatonin. And here's why. Over-the-counter melatonin, it comes in a 1, a 3, a 5. What occurs is it's not addictive. There's no, withdrawal profile, but you do develop a tolerance for it. So if you start out at 1 milligram, then you're taking 3 and 5, then you're maxed out at 10, and you're still not sleeping. So it works. If it works for a brief period of time, and then you lose efficacy and you have to go to higher and higher dose, and eventually it's just ineffective. It can be an adjunctive treatment. Melatonin is great for if you are traveling overseas and you need to reset your circadian rhythm. That it's perfect for that. And so it can help a lot with jet lag. But aside from that, really, there's not a lot of strong evidence for melatonin, although Romeltian is a step above that. And there is some evidence for using that medication, but it's by prescription.
And sticking with the melatonin theme, is there any other information that you would like to provide with children, or as children taking melatonin? With sleep, would you give that same recommendation for children and melatonin?
Yeah, it's a very benign medication. Melatonin and Benadryl, you can get them over the counter. Benadryl, which is diphenylhydramine, is the only ingredient. If you're looking at ZzzQuil, there's NyQuil, DayQuil, ZzzQuil, they're just little, very expensive, small purple Benadryl. That's all it is. It's the only ingredient. So those over-the-counter meds, they're equally efficacious, which is to say some people notice a benefit. But I think in the child and adolescent population, children in particular, the nice thing is the side effect profile is very benign. They don't work on serotonin. You don't have to worry about changes, in neurotransmitters. Benadryl works on histamine, melatonin works on melatonin. Your body makes melatonin anyway. So they might help, they couldn't hurt.
Okay, another question here. Could you please give an example? Oh, the question just popped. Could you please give an example of a nightmare reframe?
Yeah, sure. So I had a client, I'm fortunate because the residency program I went to allowed us to do electives, and I did an elective in sleep medicine. So I actually worked with a psychologist and a therapist to learn how to do IRT. So I can recall a client recently here who had a nightmare that they were it wasn't associated with PTSD, it was nightmare disorder. And the nightmare was that they were in a building with their family in a high rise, and a tsunami was coming and it was wiping out the entire building. And they were turning around and they were seeing their loved ones get swept off by this tsunami. And they were reacting with feelings of helplessness and horror. So we took that script and we reframed it into something in which they were more empowered. So they reframed it into a day at the beach. And their family, the little waves that come up, you got the big waves and you got the little ones. Their family, they were holding their hands and they were swinging and jumping over the little waves together and laughing and having fun. And it was kind of empowering because it kind of took back that water image and that fear and turned it into something that was a pleasant, enjoyable vacation. So when they saw that water coming, they literally shrunk the tsunami down until it was these little trickles of the waves that roll up on the sand. And it was no longer frightening. And they were able to really fall asleep and they didn't have that nightmare. The other thing about IRT, long-term studies, a year later, they were still not experiencing that nightmare. So that's a great example.
This one is regarding a question about a combat veteran. How would you advise a combat veteran to write out a nightmare if they're stating that they do not remember the nightmare?
So it is challenging to do IRT if you can't remember the nightmare, but my specialty is PTSD. I would suggest that if the nightmares are that bothersome and they're leading to intrusive thoughts during the day, hypervigilance, hyperarousal, possibly dissociations, flashbacks, perhaps what they really need to do is delve in to prolonged exposure therapy instead, because you've got these symptom clusters, and if they have a diagnosis of PTSD, nightmares are a small part of it. So trying to process through some of these past events rather than trying to process through a nightmare, which could be a bit more amorphous, and really processing through actual events that they recall. That's what I would recommend. And then we can get to the nightmares after they started doing some PE work and gained some traction there. What do you think, Dr. Izmirian? Is that your recommendation?
Yeah, I agree. As you know, because I also have that experience with prolonged exposure. It's same thing with doing the trauma work. It's hard to do it with if you don't have the actual memory. So I think I agree.
Okay, this one was a question regarding. Go ahead.
I was just going to say, just to emphasize really quickly, you don't have to have really well-formed memories to do PE. PE at its heart, it's an emotional processing. So we're talking about how those traumas made you feel then and how they're still impacting you now. So, you know, the memories are a part of it, but you don't have to have these distinct, you know, memories in order to begin processing, because again, it's an emotional processing.
Thank you. This question is regarding teenagers and children. Oftentimes, teens and children take naps during growth spurts. Would you consider this, you know, normal, or did you have any additional comments to add about, you know, teenagers taking naps?
I think this depends on if it impacts their sleep at night. This is where, again, I think it highly depends on, you know, your kid or the parents know their kids. If they take like a, you know, like, and again, I typically recommend for it to be less than an hour and not after 3 p.m. But if they take an hour nap or so, let's say like right after school, because it's been an exhausting day, but they wake up and they can still do their homework. They can still go to bed at whatever their normal bedtime is and wake up normally and without a lot of pushback and fighting, then I don't think it's an issue. I think it becomes an issue when it starts impacting them and they take like a 3-hour nap and then now they're staying up until 12 a.m., 1 a.m., and then they can't get up for school the next day. So I think, again, highly dependent from kid to kid, but more important when you're noticing that it's actually affecting their day-to-day sleep.
Okay, thank you. This one is next question is about sleep diaries. You know, someone had commented that they're really having a hard time getting some of their clients to do a sleep diary. Any tips or tricks that you have found very helpful to get their clients to use a sleep diary?
Yeah, this one's a tough one because I've had that same experience with certain individuals that are just having a tough one. So sometimes people are like, no, I really want to use the app. And then they just wake up and forget to use the app. So you just might have to have other methods. So paper. For me, my personal experience with CBTI app, because I tried it on myself because I'm like, if I'm going to have my patients do it, I'm going to try it myself. The alarm, the reminder on the app itself, the CBTI coach didn't go off. So I just set my own reminder. But using paper can be another alternative, a paper right next to your the nightstand. I had one patient, because the paper wasn't working, the phone wasn't working, whiteboard. And it was a whiteboard that they went by every single morning. Like, you know, you put the whiteboard, let's say right by the restroom, because, you know, you're going to use the restroom every single day when you wake up. So I would try to find something that they do every single day and connect it with that if possible. That's one strategy, but that I've been in that very similar situation where I've had some people who are just like, there's something that's getting in the way of them writing it down. And maybe it's something else that they're not talking about. And so maybe doing a little bit of MI and motivational interviewing to determine like what's getting in the way there. I've had some people, if it's like younger crowd, if they're still living with their parents, where their parents are the ones that are like helping them to do this, like whether it's a sleep diary, like, and to get out of bed, like when we're talking about like sleep restriction therapy, of like, you know, get out of bed every day by X time, 7 a.m. And if they can't, like their parents, even if they're adults or kids, like their parents are the ones getting them out of bed. And so maybe having like a support individual, whether it's a partner, a parent, a friend, like help them to remember to do that. So that could be one option. So yeah, reminders. If they're on the younger side, maybe a reward of some kind of like, you can only get your, I don't know, favorite breakfast coffee or dessert, you know, like, or breakfast food if you do the sleep diary. So you can connect it with something rewarding as well. But I've been in that situation. It is a tough situation to be in. So,
and this may be on those same lines as kind of any additional, you know, tips, because you did talk about TV watching. But this next question is, how can we explain why some people, quote unquote, need or want to watch TV to help them fall asleep, but they only feel like they have to watch TV to fall asleep? You talked about, how maybe this is more of, a behavior that you'd want to, try to help, a client change. So any other, again, the question is this okay, or should we insist that there's no screen time? I know you did mention a little bit about this, but anything that you'd like to add?
Again, if they don't have insomnia and they don't have sleep issues and they want to fall asleep with the TV on, that's okay. It's not impairing them. But if it's impairing, I typically do recommend to not go down the sleep route as like having the sleep on in the background. Because I did talk about the cadence and the volume, but also the bright lights. Like, when you're going from a programming to a commercial, it might be a dark show and then it goes into a really, really bright commercial. So even if the TV is like volume is super low, but the lights itself can impact you. So if you're having sleep difficulties, I typically, again, don't recommend that. I think white noise machines are, I can't remember, like 10 to 20 bucks on Amazon. So I'm just like, or even just a fan, something along those lines, something else. I typically do recommend that. I think you might want to get more information from the patient too about like what specifically about watching TV is the thing that's helping you fall asleep. So is it that it's drowning out noise from the background? Then we might need to change, affect that piece. Is it, I'm trying to think of like, because the white noise machine actually helps, like it covers their own anxious thoughts and they don't have to think about their thoughts. Then we might need to do cognitive behavior therapy or other strategies to affect the anxious thoughts. So I think maybe, digging deep a little bit on like what exactly is it there that they need the TV piece. So.
Okay, this next question. I work heavily with clients who have ADHD. And I've noticed that they are constantly struggling on sleep. Is there any additional research that, either one of you may have on this, or that could be helpful to provide some additional insight?
I'm not sure if I specifically looked into this specific tie of ADHD with this, but yeah, Dr. Kramer, do you have anything specifically?
I haven't looked into it specifically either. I can tell you one thing clearly, and I think this is pretty evident from a pharmacotherapy standpoint, stimulants are stimulating. So, trying to ensure that by the time they're getting ready to go to bed, that whatever stimulant they are taking, if they're on a stimulant, that it's worn off, because that can really affect their ability to fall asleep if they're taking it too late in the day. So even with adults, I tell them, okay, if you're not going to take something that is long acting and we give it in the morning and you're taking a short acting med, I don't want them to take it after 1, really, because that half-life is such that it really could affect your sleep. So other than that, I really don't have much info. But yes, I would be cautious with taking any medications that are stimulating later.
Okay, this next question is about, how about for those who struggle with restless leg in bed at night? Any tips on that for sleep?
Well, there are some actually pretty effective pharmacotherapy agents for restless leg. So, the issue is that it can, be clearly a medical condition. If someone is feeling restless and anxious at night, that's different from an actual restless leg syndrome, which is a medical condition. You also want to rule out other medical conditions. So you want to rule out akathisia, which could be a side effect associated with a lot of medications, which people describe as an inner sense of restlessness throughout the whole body. So you want to rule out med side effects. You want to rule out other diagnoses. You want to rule out vitamin deficiencies. Restless leg is so commonly comorbid with vitamin deficiency. So get a full, toxic metabolic infectious workup to make sure that it's not related to either medications or to a medical condition. And if after you do that, diagnosis of exclusion, they still have restless legs, there's some really good medications that help significantly with restless legs. I would just I encourage them to talk with family medicine even, or, clearly a psychiatrist can prescribe as well.
Okay. And, anything to add for perhaps adding, these additional tools or tactics like blue glasses or weighted blankets?
I think blue glasses are great if they help for you, especially if you're going to be one of those individuals who works behind the screen all day. And I'm trying to think, and I think this is also part of the reason why we want to limit screens toward the end of the day too, when it comes to that. I didn't specifically read anything about weighted blankets, but I think it goes back into when it comes to that sleep hygiene strategies of like, find the thing that's comfortable for you when it comes to that piece. I know some individuals feel suffocated by the like heavy weighted blankets, and then some people love it. So I think this kind of goes back into it's per individual and if you find it helpful, but I haven't specifically read it, like the connection to it in relation to CPTI or anything along those lines. So I'm not specifically knowledgeable about those pieces. So.
Okay. Just probably time for one or two more questions here. Just lots of comments on how great this presentation was. So let's see here. Any more suggestions on where one could get any additional training on CBTI? And there'll probably be on that resource questions. Right,
I was like, it's on the next slide.
I'm just reading that. Yeah, so we will get to that here in just a few minutes on that next slide. Let's see here. One more question I think we'll have time for. I have patients tell me that they cannot sleep because of their anxiety. How do I know what to address first, the sleep or the anxiety?
I think similar to like the PTSD versus sleep question, I think it depends on the patient and which one is the most impairing for them at this moment and which one are they mentally ready to tackle right now. And honestly, you could probably do a little bit of both at the same time if you have that flexibility in the approach that you take. I typically, I kind of lead the guiding piece there for the patients to be like, this one is the impacting piece. So let's focus on whether it's anxiety or sleep. This one is the one impairing my life now the most on a day-to-day basis. So we'll tackle that one first. But honestly, if you go the sleep route first, kind of like within about 3 or 4 sessions, you'll be able to still do some cognitive restructuring or some other anxiety-related strategies while you're still doing a session on CBTI.
And I can tell you with, my residents, a lot of times clearly they're going to have insomnia, whether it's related to, nightmares or, comorbid OCD. They're stuck up at night with these negative, obsessive thoughts. People can get stuck in anxious ruminations, depressive ruminations. So part of sleep hygiene is focusing on getting that parasympathetic nervous system, into gear, rest and digest, and focusing on something that is more positive, that's relaxing, so as to ease you into sleep. So you don't want those worries to be prominent when you're going to bed. Now, if they have anxious worry 24/7, I would say possibly let's get the anxiety addressed first. If they're having panic attacks and then that's affecting their sleep and their work and their social and occupational functioning, let's address the anxiety because it seems like the sleep may be secondary to the anxiety. But if they're anxious at night, again, it's either or, whichever one you want to address first.
Thank you so much. Well, that's all we're going to have time for today for these questions. Remember, if I did not get to your question, please feel free to send an email to webinars@rogersbh.org, and we will follow up with you. Many thanks today to Dr. Kramer and Dr. Izmirian for taking the time to share all your valuable insights with us today. We thought this was a great webinar. There's so many wonderful comments of how informative this was. Before we conclude, I'd like to ask that we're going to share some additional resources on our topics with our participants. So these are some of the examples of some additional resources that we have. So that's going to be a wrap today for everyone. I want to remind the participants, for those of you that have met the required time commitment, you will be eligible for CE credits. Within the next 30 minutes, you will receive an email with a link for your personal dashboard on cego.com, where you'll be able to access the PDF today of the PowerPoint slides as a handout and complete with a complete list of these references. For those of that you have met the time requirements for the CE, you will complete evaluation. If you could please complete the evaluation to download your CE certification for this event. If you have any questions about the follow-up email, please contact the support at cego.com. On behalf of everyone here at Rogers Behavioral Health, we look forward to partnering you with your patients. Please reach out if you have any questions. I'm your contact person that was originally listed on your invitation. You can always reach out to me for any questions regarding Rogers Behavioral Health. So thank you for joining us today. We appreciate you taking the time and joining us for this event. Have a great day, everyone. Thank you. Bye now.